Hi, welcome to Straight Ahead. I'm excited to bring to you our guest, Katy Talento. You probably saw Katy in our first release of this series in a pre-recorded interview that we did in Washington, D.C. And I'm excited to bring her back today on this Facebook Live to talk more current issues of what's going on with COVID-19, as well as more of our discussion on price transparency. So, Katy Talento, welcome back, I should say, to Straight Ahead.
It's my pleasure. Thanks so much for having me.
Thanks for being here. Now, Katy, since you and I spoke last January and everyone saw that interview, since we spoke, your title has changed a little bit. You're still a healthcare policy expert and advisor, but you're also now the executive director of the Alliance of Healthcare Sharing Ministries.
That is right. We were cooking that up a little bit the last time. We couldn't say anything, but now we can.
I love it. I'm so excited. And honestly, you know, when the Alliance was looking for an executive director, I had seen an interview with you, and I'm going to forget the podcaster's name, but it's part of the Prager universe.
Owens.
Yeah, Candace Owens. And I thought, wow, this person gets it. This would be a great fit. And then you were part of that short list and being interviewed. So you've been such a gift, I think, to the other ministries. I've been hearing about, I'm not in the meetings, but you know, with Brad Hahn, our CEO, and the other ministries working together. So been a gift to have you as a voice for healthcare sharing.
Thanks. Well, it's a gift to be associated with healthcare sharing. I love disruptive healthcare models, and especially when they involve Jesus. So it's the best of all worlds.
It's amazing. Now, tell me what, you know, having been in that role now for 4 or 5 months, what would you say to people out there that are watching? Why are healthcare sharing ministries kind of the wave of the future? What do you see as the promise there?
Oh my goodness. Yes. Well, one thing I love about it is most healthcare sharing ministries are based on preserving the relationship between patients and doctors so that we get all the middlemen out. And it's the middlemen that are driving up the cost and driving down the value, who have incentives that aren't always aligned with the patients. And so I think it's the perfect model, especially I know that Solidarity does this, but there are some others as well, especially those who really use transparent pricing and self-pay discounts, which I love that because it really puts the power in the hands of the relationship that matters in healthcare, the doctor and the patient.
Amen. Yeah, it's been such a refreshing piece to have somebody who gets that as part of this team. And I think, you know, as we've gone about and I think you and I kind of know a lot of the same people who are influencing in different spaces of disrupting healthcare in the provider space, in the surgical center space, and the imaging, and all of these groups in the benefits world. It's been really neat to see as everyone's got their flag and they're all fighting a battle on a different front. And I think healthcare sharing is absolutely one of those fronts where we can impact a lot of people. And really, for Solidarity HealthShare, it's always been our mission to develop this authentic Catholic healthcare culture. But honestly, it's also about inciting that change, that hopefully we can help change the entire healthcare landscape with this influence.
Exactly. And there are lots of disruptive models out there in the self-insured space and elsewhere, but nothing is like healthcare sharing because those other models don't have the spiritual element.
Right.
And so there is nothing more personal, more intimate, more spiritual than your health, your body, the loved ones around you, and the human dignity questions. So there's no way in my mind as a believing Catholic, and I know for many others, there's no way to extract the questions of theology from the questions of medicine.
Wow.
And science. And so I think that the union of the two is so important. There's been this false dichotomy it's set up as this false dilemma between faith and science, as if they're mutually exclusive.
Right.
That the secular world has sort of imposed that ideology on us. The church and the faith have never been extracted from truth. And so to the extent that science is the pursuit of truth and faith, is truth, then they're inextricable from each other. And so the idea that we would separate artificially, I think, segregate health from matters of faith, it's crazy. The first thing anyone does when they find out they have a terrible or scary diagnosis is they pray. They pray and they talk to their loved ones. I mean, it's so personal, intimate. So that's why I love being a member of Solidarity HealthShare, and I love the whole healthcare sharing ministry model. I hope more and more people figure it out and that the model grows.
Yeah, I thanks for saying that you're now a member of Solidarity. We love having you, and I love having people like you who are in this space because you know what we're trying to do. You know the areas where we can improve. You know what's going on out there, and so having voices like yours as part of the ministry that are helping drive us to be better is really a great thing. And to what you said, I think one of the most fruitful things I get to do every day is hear about the members that we're supporting spiritually. Obviously, the payment of bills and the timely payment and all those things and sharing of medical bills is a primary task that we do every day. But that when I get the email from somebody saying, hey, so and so is going through this, we need to pray, and everyone gathers to pray in our chapel, or when our pastoral care coordinator shows up to our office and has a bunch of cards that we need to sign for people who have just had miscarriages, and those are real things that we get to be a part of that nobody else is doing out there, right? And we hear from members all the time about those things, that those aspects. I know when I was going through my late wife's cancer, that was the piece that was missing, and it was the church who provided that.
That's right. That's right. And I think that there are a lot of people out there who are negotiating medical bills, or who are finding innovative and disruptive ways to do the what that we do, right? What is the what that we do? Well, we facilitate the payment for medical bills, and we negotiate discounts for those bills, but why do we do it? Mm-hmm. Right? And I don't think you can go to an insurance company. They're going to have a different why. Their why is profit, and in some other way, some other motive. But for healthcare sharing ministries, we do what we do because of our faith in Jesus, right, and our love for neighbor, and
our call to serve our neighbors. Yeah. So tell me, I wanted to talk to you. I was excited to be able to do another conversation with you. It's in May. We're May of 2020. For those watching this, we're kind of in the midst of the coronavirus piece here in the U.S. and in some ways on the tail end. Some communities are opening, like ours in Arizona. Is opening today. What people probably don't know about you is that you're actually an epidemiologist by training. And so while I know that all of my friends on Facebook actually are now qualified epidemiologists as well, I've learned in the last 3 months, I wanted to, since you're the one who taught me how to even say epidemiology, I wanted to ask you, what do you think of all of this? Where are we at? Have we overreacted? Have we underreacted? Any of those pieces that you could speak to?
Yeah, great question. So I think it was just today, maybe yesterday, one of my good friends, Marty McCary, published an op-ed in the New York Times. And Marty, he's a surgeon at right. Johns Hopkins, and
world renowned, great guy.
Yeah, we went to grad school together, and so we sort of mirrored each other's careers in health policy, and so we conspire on these things, and we put our heads together a lot, and we've been talking a lot about coronavirus, and he and I have had the same reaction at the beginning of the epidemic, or even before we knew what the epidemic would be. At the beginning, we both were very strongly supportive of the lockdowns when we didn't know what was happening, and this very scary, very quickly transmitting respiratory disease. I mean, it's every epidemiologist's sort of doomsday nightmare scenario. And so in that sense, I mean, I was writing op-eds. Everybody, here's how you prepare for a 3-month lockdown, and go get your, Walmart stock ups and, get pet food and start hoarding. Because I thought that we might be locked down, even though none of us had ever seen that in our lifetimes in America. But it was that scary. And so then as time went on, we've learned a lot about this. And I think there is a huge amount of data. I mean, I don't want to overstate it. There's still so much that we don't know, but we know now who is really at risk. And so I think we're starting to see, well, these models, they actually weren't wrong. I mean, they predicted what are the death numbers if you have a certain amount of social distancing or other mitigation measures, and we're kind of on track, tragically, for those numbers. So I think as we get the countermeasures in place, we bought ourselves time with those lockdowns. We bought ourselves time to get our healthcare capacity sort of sorted and set. We've got our PPE supply chain going. We've got a lot more information now about therapeutics, which ones might work, which ones don't, how to clinically manage the disease. I think providers around the world, doctors and other experts around the world are starting to have better protocols and sharing information about what protocols work clinically if someone's in your hospital or your ICU. So all that lockdown bought us time because it slowed the transmission. And I'm grateful, and I think it was important to do. And certainly we have you can't develop a test for a disease that doesn't exist or that you don't know about. And so it took us time to get tests developed and a supply chain for those sorted. So, when those lockdowns first occurred, the only, data that we had, the only example we had was China, which we didn't really want to imitate their approach, and Italy. We were seeing Italy, and it was a bloodbath. They were overrun. It was a train wreck, and it was not something that we wanted to happen here. So all that to say, I think the lockdown was the right thing. Equally, I think it's time. Right? America is ready to start doing its own risk assessment. Americans, we're capable humans. We are mature, responsible people. We are parents. We are employers. We are employees. And we know how to assess risk in our own lives and in the lives of our loved ones and in the lives of our businesses every day. And so we do that whether we're going out on the road, and whether we're getting in a plane, a big plane, a small plane, are we going to get on a train? Who are we going to hire to take care of our kids? What kinds of food are we going to put in our mouths? We take risks every day, and we make those calls every day. And it's time to let Americans do the same and with this disease.
Yeah, that's a great way to put it. I think that the data, we're seeing more data now that's showing where we're headed, and those are good. How would you recommend? I think obviously this is going to continue. So, as even at Solidarity HealthShare, as we're thinking about when do we bring our staff back in the office versus they're all working from home right now. And, we've actually had 2 staff members get COVID. And so it was actually great that we had them at home and, they were able to, in fact, the one who was still symptomatic actually worked most of her time. And, we finally had to tell her, no, you need to take time off. But it was actually a good thing, right? So as we're making those decisions, this is going to keep going for a little bit. How do we protect? How does the individual patient protect against just the conversation we had in January, the price gouging that might be related to COVID or the other issues related to COVID, that could come about? I know you've been involved with some of these letter writing, projects to HHS trying to protect the cash pay patient. What should we be doing as Americans when we come up with this to make sure we're not getting gouged or, led to the cleaners here?
Right. Well, first of all, some of the legislation that has rolled out of Congress in the past couple months on coronavirus has provided some protections. So if you're getting a test and you're presenting at an ER or an emergency room or an urgent care asking for a test, symptomatic, and you're qualifying for a test, and you should not be charged any cost sharing for that test. So that is the first question. If you're on, an insurance plan, right? That's the law. But for those of us who are not on insurance plans, we need to be careful. And the thing to do is don't be careful about showing up. Go, if you're symptomatic, please go. But the same techniques that you and I, Chris, talked about in our last time together still apply here. So when you show up in an emergency room, and everyone who has any reason to be in a doctor's office or an emergency room, and they give you those forms, and it's always some, administrative clerk in her 20s who's saying, "Oh, this is just to give us consent to treat you," and I always look and I'm like, this is a lot more than just consent to treat me. Right. This is consent to bill me whatever you want. And so on those forms, do not sign those forms in an emergency room. In a doctor's office, you usually have to sign them. But in an emergency room, you don't have to sign them. They're required to treat you by law anyway. But if you want to protect yourself financially, write out, there's a battlefield consent form. You can Google battlefield consent form for an emergency room, and you can go to quizify.com, and they have it for free. You can download it to your iPhone in the Wallet app, and you can always have it with you, or you can print out copies. And I know some innovative employer plans are putting little stickers on people's insurance ID cards that say these words, and the words are, I consent to appropriate treatment at a rate of no more than 2 times the Medicare rate. And you can pick the number you want, 1.5 times the Medicare rate. Is probably where I would start. But yeah, so when you sign your name to that, and the provider, the doctor, the hospital takes that and doesn't contest it, that's really good leverage if they come after you. It's not necessarily bulletproof, but it's almost bulletproof.
Yeah, it gives people like us the ability to help fight on your behalf. That's for sure.
Exactly right.
Yeah.
That's exactly it. It really empowers your sharing ministry, because people like your vendor that I think you're going to talk to, AMPS, next week, but the people that we use to negotiate with doctors and hospitals, we need every tool we can get to advocate for you. And so this is the perfect tool for them.
Right. Now, tell me, we just have a couple minutes, but one of the things that I've really enjoyed, in some of the community that we're both connected to, is the conversation about primary care, and I think we've talked about direct primary care possibly before, but around a good value-based primary care system, because I really think that a lot of people are right that if we had that in place in America, which we really don't today, we would have been able to handle this COVID crisis in a much better way, right? So how do you think this is an opportunity, and I guess, is this an opportunity to kind of highlight that need for good quality primary care in America?
I certainly hope that, to quote Rahm Emanuel, that we do not let this crisis go to waste when it comes to getting important policy done that needed to be done before Corona and will still need to be done after Corona. And really creating a new payment model for primary care. You get what you pay for, right? And if you are paying for sickness and you're paying for hospitalizations better than you're paying for disease management, better than you're paying for primary care and prevention and wellness, then you get more of the sickness and hospitalization and complications. And so we need to turn that around, and direct primary care and direct care of all types, specialty care as well, can fall into this model. But essentially, high value direct primary care is basically, rather than paying a doctor for the 6 minutes that they spend with you after you've taken off that half day of work to get them, with an appointment 3 weeks in advance, what direct primary care is you're paying a monthly rate, or your insurance company, or your healthcare sharing ministry, or your health savings account. You're paying a monthly rate to a direct primary care provider. And that means that you get all the care that you need. All the primary care you need is paid for in that rate. So you can see that person, you can see that doctor in person, you can text with them, you can email with them, you can Skype with them. And now we all know how to use Zoom. You can Zoom with them. And so you can get the right kind of care in the right setting at the right time. And that's the important thing. So now that doctor, all her incentives or his incentives, they are to keep you well. They do better if you cost them less. And then what's even better is when you work into the contract with the provider, hey, we're going to pay you more if you achieve these health outcomes. So let's say I'm an employer and I have 10 diabetics I'm going to pay you more if you keep these people off dialysis or not needing dialysis, if you keep them from not going into kidney failure, if you keep their glucose numbers great, right? So that realigns the incentives to match the incentives of the patient. What does the patient want? The patient wants to stay healthy.
Right.
The patient wants to stay out of hospitals. That's not what our healthcare industry wants, because that's not what rewards them. So aligning the incentives that we spend less money and that we have greater healthcare and that we are more healthy, that is what we want to pay for. So I love the direct primary care model. And what's really important about it is, first of all, it's a win-win. You get better care and you spend less money. I mean, how often can you say you get better quality for less money? There aren't many products and services out there. So primary care is such a win, and it's really saving doctors too. They didn't go to the business to be in this like hamster wheel corporate industrial complex. And they want to go back to that relationship with the patient where they're not just glorified billing clerks and their electronic health system isn't just a glorified cash register. They want to be in that loving, trusting relationship with patients and doing what's right for them.
I love it, Katy. And I absolutely, one of the reasons why we at Solidarity consider the provider our second customer is because it's so important that we prioritize that relationship, with the provider. And, you and I will talk soon, I'm sure, about some of the things we're moving towards to do that even more, to make sure that providers. Now, I've got to go. They're telling me that, we only had a certain amount of time, but I know you and I could just go on for a long time. So I'm looking forward to the day that we get to have a glass of wine together in person.
Yes.
But thank you so much for what you're doing to advocate for healthcare. Thanks for being a member of Solidarity. And thanks for, being out there fighting the fight for us. God bless you and stay safe.
You too, Chris.
Thank you so much for joining me for Straight Ahead. Keep coming back each week. We have many more conversations coming your way. This has been a great conversation with Katy Talento, and you can find out more about what she's up to through her channels on Facebook, Twitter, and LinkedIn. God bless.